A very good afternoon. Central serous chorioretinopathy, or CSCR as we all know, is an exudative retinal detachment at the posterior pole, predominantly affecting middle-aged males. Though it is known that the disease is caused due to an abnormality in the RPA pump mechanism, but the etiopathogenesis of the disease is still under investigation. Most of the cases are idiopathic and there are multiple hypothesized etiologies. Today I shall be presenting a case of CSCR which the patient developed after an episode of angioedema. This is a kind of a case that has not been previously reported. A 37-year-old male was referred to us from medicine department with a history of sudden paleness, diminution of vision of the left eye. He gave a history of developing angioedema 2 days prior, which was managed with a single dose of corticosteroid and antihistamine, followed by oral antihistamines for 2 days, with which he had resolution of symptoms. At presentation, the patient was stable. The right eye examination was unremarkable, except for a finding of a cup-disc ratio of 0.7:1 with a healthy neuroretinal rim. The vision in the left eye was 6/18 parts with no further improvement. On anterior segment exam, we discovered a wedge-shaped lenticular opacity in the nasal quadrant. The cup-disc ratio in this eye also was 0.7:1 with a healthy neuroretinal rim. And the posterior poles showed a 1.5 disc diameter size detachment of the neurosensory retina with clear subretinal fluid at the macula. The IOP of this patient was normal. These are the pictures, initial pictures of the patient, the color fundus and the red tree picture. The OCT of the right eye, OCT macula of the right eye was within normal limits, and the left eye showed a characteristic dome-shaped elevation subfoveally. The central macular thickness at this point was 629 microns. The fundus fluorescence angiogram showed a pooling of dye in characteristic ink blot pattern in the left eye. These are the pictures, initial pictures of the patient. So, with the clinical presentation and initial investigations, we came to the diagnosis of CSCR left eye. And since this was the first episode, we took the course, conservative course, and we decided to observe the patient for spontaneous resolution of fluid. But over a period of 3 months, the patient did not have complete resolution of fluid, so he was started on tablet eplerenone, 50 milligrams OD, after systemic workup and counseling of the patient regarding the adverse effects. We gave the treatment for 6 weeks, during which we saw a resolution of SRF, which continued over the next 3 months, finally leading to complete resolution of SRF. OCT macula also showed signs of chronicity initially in the middle part of the treatment and followed by complete resorption of fluid. So these are the progressive OCTs. The first one is at presentation. The second one is at 3 months of treatment, where we can see a shallow SRF and subfoveal hyperreflectivity. And the final OCT is complete resolution of fluid, but the foveal thickness has come down. So the present status of the patient is the vision is 6/6 parts. There is some residual metamorphopsia. Patient is presently not on any drug and has not reported any recurrence of the symptoms. In view of the increased cup-disc ratio, we also took up a glaucoma workup concurrently, which was unremarkable. And the cataract that we discovered in the left eye was did not progress with time. This is the glaucoma workup that we did. The OCT RNFL showed an increased cup-disc ratio, but the NRR, as we can see, is normal. The right eye visual field was normal. The left eye showed a central scotoma, which is consistent with CSR. CSCR, an exudative retinal detachment, the causes are largely idiopathic. There are many etiological factors which have been hypothesized, most importantly chronic exogenous or endogenous steroids and other drugs like antihistamines or proton pump inhibitors, GERD, pregnancy, H. pylori. But still the causes are under investigation. Under research. The patient characteristically presents with diminution of vision central scotoma with metamorphopsia and micropsia, which was the characteristic presentation in our patient also. Multiple modalities of treatment have also been suggested, including medical management with eplerenone and other drugs like rifampicin, finasteride, mifepristone, and laser therapy, micropulse laser, photodynamic therapy. Also intravitreal anti-VEGF, but observation still remains the first line of treatment. So why was our case unique? First of all, even though we know that chronic steroid and antihistamines have been reported as etiological agents, And in an hyperacute setting where there has been a single dose of steroid administered, we have not seen any such cases. During our research, we did come across one case report of CSCR happening in a patient with non-histaminergic angioedema who was on steroids in tapering doses. But our patient had responded to antihistamine and he was not on any long-term steroids. Regarding cataract, I came across a research with 2 patients developing cataract on chronic antihistamine therapy. But again, this was not the case in our patient, so we regarded the cataract as an incidental finding. This is the first case of CSCR which was reported after an episode of angioedema, which was responsive to antihistamine, and there was no history of chronic drug intake. To conclude, CSCR is a very common yet still mysterious disorder which is still under research. And chronic endogenous or exogenous steroids have been associated with CSCR, but angioedema as yet has not been reported as a causative agent. Also, in this circumstance, the role of endogenous steroid response and external administration of drugs such as steroids and antihistamines in a hyperacute setting need to be explored as a cause of CSCR. These are my references.